Well, good morning. Good to see you all. It's not quite 9 o'clock, but I'd like to welcome you all to another one of our webinars today. We're very happy and privileged to have with us Professor Andrew Baildham. As you will have seen from his bio on the poster that we sent out, he's a very well qualified surgeon, trained in surgical oncology and then breast plastic reconstructive surgery. He's a lecturer and also has a tertiary surgical practice in Manchester and London. He's married to Eileen, who's also a medical doctor, consultant pediatrician. So we're very happy to have you with us today, Andrew. Thank you for taking the time to be with us. The title for the seminar today is Following Your Calling. How does this affect your well-being and impact the well-being of others? So we're anxious to hear what you have to say to us today. Thank you for coming, and the time is yours.
Thank you very much for that introduction, and it's a great pleasure to be with you this morning. I've thought about this talk for quite some weeks since I was invited to do it, and what I'm going to do draws very much from surgery. It's not a lecture. A lot of it's a story. I hope you find it very useful and interesting. And I'm not going to give you just a series of tips about your well-being or your health, because that isn't the purpose of this. Neither can I, as a medic, give you a sermon type of presentation, because that would be a bit like a clergy person coming and talking to medics. But there's a lot of crossover between medicine and the church. So following your calling, and I was given a pretty much blank page to fill in here. The calling, vocation, Latin. I did Latin at school. I was probably one of the last generations that did. And the Latin word vocatio, I call. And we talk about the church being a calling. We used to talk a lot about medicine being a calling, certainly being a vocation. So what I'm going to do is just tell you a little bit of what I do, and then I'm going to dig back into how that happened and where I see it now. Well, I thank you for your introduction. I have been a consultant surgeon now for over 25 years, initially in Manchester and then in London at Barts. I've been a professor of surgery at university teaching hospitals. This is fact, it's not bragging. I'm an international expert on breast cancer. I've devised a lot of surgery for breast cancer. I do a lot of reconstructive breast surgery. I teach, I lecture, I train. I've written hundreds of papers, book chapters, articles, and reports. I train and examine other surgeons. I act on the examining body of the European Board of Surgery. And I have a huge weekly patient practice. Most weeks I operate 2 days a week and do clinics the other days. And I love my job. I love my patients. It's hard. But I do it, and I'm so grateful to Eileen, whom I adore, who's always there and has actually been the total rock and support to keep me through this. Over the last few years, 2 books have appeared on surgery and on being a surgeon. One was written by Henry Marsh, a neurosurgeon, and that was called Do No Harm. These are widely available and widely read books, and I hope at least some of you have seen them and even read them. So Henry Marsh wrote a book called Do No Harm, and it was a bestseller about 4 years ago, and it was quickly followed by a book called Fragile Lives, written by Stephen Westerby, who's a heart surgeon. And both of them outlined the extraordinary things that make up being a surgeon. But coming through Henry Marsh's book is a feeling of depression at failure. And Marsh says how he struggled with that all through his career. And that was the title of his book, Do No Harm. And he rather depressedly says, you know, did I do any good in my career? Because he's now retired. Of course he did. And Stephen Westerby is very interesting. And I've spoken with Stephen, and he describes that to be a successful surgeon, you have to have at least in part a psychopathic personality. I won't go into the reasons why he gave that, but Westerby has been central to developing extracorporeal heart pumps and done extraordinary work. And I think what Stephen was really saying was that you have to get inured to the fact that your patients, particularly in heart surgery, may not make it. But I thought both of these books didn't really get to the heart of how I feel as a surgeon. I'm going to spend a few minutes reading to you from another book. And it's a story about a patient who has come into the hospital with a ruptured aorta in the abdomen. So it's burst. And until not that long ago, that was unsurvivable. Let me read to you. We park outside the accident and emergency department and I run in. In the resuscitation area, I talk to the patient who is barely conscious and examine him. It's exactly as I've been told. He has tender pulsatile mass in his central abdomen, pale cold legs, absent groin pulses, and has clearly hemorrhaged a great deal already. He's been temporarily halted in his state of decline by intravenous fluids and blood, but he needs surgery immediately. We talk together about the reality of the ruptured abdominal aortic aneurysm, the AAA, the inevitable death if we don't operate, the still significant chance of death if we do. I explain it all. He signs a form which gives us consent to proceed with surgery. He's desperately ill, but still takes a moment to tell me about his disabled son that he and his wife look after at home, the gadgets he's made to ease daily living for them all. His wife won't be able to cope without him. Up in the operating theatre suite, I find little sense of understanding of severe urgency. I feel unavoidably I have to explain to the junior duty nurse at reception that our patient is dying and we need operating theatre space immediately. The theatre manager has gone for a break and we have to disrupt the planned theatre timetable for the rest of the night. A non-critical patient with a small infected abscess is about to be brought up, and I have to call the gynecology registrar in a classic case of pulling both rank and clinical urgency. The nurse says we cannot send for our patient until cross-matched blood is available from the hematology laboratory, but we already are pouring in uncross-matched type O negative blood, the one and only blood type which we can give to almost anybody with minimal risk in case of extreme need through pressurized intravenous lines. Why is there so much institutional resistance to getting this all underway? Safety is paramount and procedure abounds to protect and support, but so much process. Sometimes it feels that the surgeon alone feels the cold, imminent closeness to the cliff edge of life and feels isolated, pushing the shoulder of the dire need to save a patient's life against slow-moving form and process. We're in the operating room. The assembled team is hushed and the focused concentration is palpable. The anaesthetist, Joe, is putting the patient to sleep under general anesthesia. He's already on the operating table, lying still and frail, the color of magnolia emotion walls. This is a departure from the usual elective surgery practice, where anesthesia is undertaken in an adjacent room with the patient then being transferred into the operating theatre itself. We prep the abdomen with antiseptic solution and the patient is still fully conscious. At this stage of exsanguination, seconds, not minutes, can literally determine the difference between life and death. The reason is immediately apparent. As anesthesia takes over, all the patient's bodily muscle tone is lost. The abdominal muscles become flaccid and soft, and asserting no longer pressure on the abdomen, the shape and tone of the abdominal wall changes and balloons out. The abdominal wall no longer splints the cavity, and the pressure on the aorta is lost. At once, it balloons and it breaks. Like the automatic speaking terrain alarm that switches on in an aircraft dangerously coming down too low over a mountain ridge. The anaesthetist reads out his crashing blood pressure in a commanding monitor. The green sterile cotton drapes are on. I take the scalpel and make the long transverse incision. To take the sharpened steel and transgress that hitherto untouched abdominal wall is a most unnatural act. There is no time to reflect on that. In the place, reflection never helps anyway. I go through each layer of the wall in curved scalpel lines across the mid-abdomen. The blood pressure has fallen quickly. Much of the muscle's blood vessels barely bleed. I ignore them as irrelevant for now. In moments, I'm inside the abdomen, moving the intestinal tract away with saline-soaked packs, giving out the handles of retractors to assistants and the senior house surgeon and the registrar, confronting the plum-stained tissues and organs of the posterior abdominal cavity. The hemorrhage has obscured most abdominal landmarks, and the tissues lining the back of the cavity are full of bright, pulsating blood. By experience, feel more than sight. My index finger pushes back firmly but gently around the back of the aorta above the aneurysm. I can see the ragged split on the bulge where it's pouring blood out. I have to dissect to the side of the duodenum and move all the bowel to get in there. And I take a Satinsky right-angled clamp, a surgical instrument designed to occlude blood vessels and anatomical tubes without damaging their walls, and push it alongside my finger. I open it and place it firmly around the aorta above the neck. The clamp ratchets on and the aorta below it sags and the hemorrhage stops. It's shutting off the aorta. Here it has a 24mm diameter above the aneurysm, bigger than a hose pipe. But I'm now dramatically reducing the blood loss, but also stopping almost all blood flow to the lower body and organs within the abdomen. They're now deprived of oxygen, but the vital arterial blood flow to the brain is being conserved. Joe, the anaesthetist, laughs for the first time. The blood pressure is holding steady and beginning to rise up. It's going up. His blood pressure's too high, she jokes. It's a brief few moments of respite. There's a lot more work to do. Using a pair of long-handled scissors, I cut across the aorta below the clamp. The aortic graft, which I'm going to use to repair the aorta, looks like a small pair of trousers made out of white Dacron, with a waistline of 24mm chosen to match the diameter of the vessel. It's the biggest by far of all the arteries in the body, like a small living hose. With proline over and over sutures, I meticulously join or anastomose the graft to the remaining cuff of aorta just below the clamp. Then I parachute the graft up onto place with the strands of surgical nylon. It snugs on the wall, the white Dacron stains red. Once in position, I clamp off the two lower trouser legs, then release the Satinsky clamp and fill the graft and test the suture. The blood blasts from above. I close it again and wait for it to clot. For a few minutes it holds. Then when I open it, the Dacron graft blows off, parts company from the wall, and once again there is massive hemorrhage. With my finger, I pack up the Satinsky and try again. This time stitching the graft even higher is far harder. Halfway through, a loop of duodenum falls out. The SHO puts his hand in and almost gets the needle right into his finger. 30 minutes later, I've replaced the graft. I take the clamp off, the graft holds for a few minutes. Then again, it tears off. This is not going to work. I realize with the existing atheroma of the aorta, it's not strong enough to hold the sutures of the graft. It's too diseased and damaged. But I'm as anatomically as high as I can possibly go. I'm wondering how long it's possible to survive with an aortic clamp in place. I've never seen an aneurysm like this. I can't call another consultant. We're a regional center. He's a single surgeon with no cover 45 miles away. I'm on my own. The operating team is silent again. There's no more chat. There's no nervous laugh. Instead, there's a sense of fear, of dread. I feel responsibility and my own vulnerability, and I can smell my own fear and taste it behind my surgical mask. My heart rate is rising. I breathe deliberately and calmly, slowly to control my own body's physiology, my own fight or flight reaction. I can see myself trying to explain to this man's wife why he died, to tell my colleagues that I couldn't save him, perhaps to be blamed by those who themselves have never ever set foot in an operating room, let alone donned a surgeon's gloves and held that scalpel in their hand. The left renal vein is coursing across the aorta, carrying all the venous blood flow back from the left kidney. It's about 7 to 8 millimeters across. Something unspoken in my mind is urging me to divide it. I've never done that. I've never seen it done. There is no way back. We are in an extreme position of no return. I can feel great runs of sweat down my back, torrents of fear. Peripherally, I think of what I'm going to say in the coroner's court, having to explain to the inquest how this patient died on the operating table. There is no way back. There is no more accessible aorta. The left renal vein is in the way. I realize it's the only option. Carefully, I clamp and divide that vein using 2 small clamps. Behind it, where the renal vein was, I find a fresh length of less diseased aorta. Not long, but long enough. I clamp it. Relief wells up in my throat. I stop holding my breath. The operating team sense this and breathe easily, but it's far from over. Another 30 minutes and the graft is back in. My mouth is dry. I'm physically and mentally drained. I click apart the ratchets of the Satinsky with finger and thumb, leaving it in place. The clamp is off. The graft floods with pulsating blood and holds. I put some patches on. I join back the renal vein, release its clamp, and see the left kidney coming back to life. I flushed it out. The abdominal organs and pelvis reperfuse and take on a much healthier sheen. And so we go on until we finish. I close up the abdomen. There's a whole page of description, but I won't bear you with that. I close up the abdomen with profound relief, put in the final skin sutures and stagger back from the table. I realize I haven't moved my left leg for about 2.5 hours and it feels numb. It's about to buckle. I become aware of my own body. My left knee is locked and painful. My green theatre scrubs are plastered down onto my back with sweat. I feel desperately thirsty and hungry and empty and drained. The mood in theatre now is light and gloves are taken off, drapes are removed, and he wakes up. The anaesthetist says, "Well done, you did fine." She's talking to the patient, not to me. I lean back against the wall, perched on a stool, and I let the adrenaline wash over. Half the night has gone, and through the one outward-looking window, the blackness of the city over myriads of sleeping souls, unaware of what we've done, glows tinged with orange streetlights. I close my eyes for a few seconds, imagining what it would be like to be asleep, but all I can see behind my eyelids is blood. And then I drive back, because it was actually a Sunday morning, and the kids were waking up, and they wanted to watch farthings of animals of farthing wood. And then I write this: I know why I decided to train as a surgeon. It's the hands, the eyes, the coordination, the self that you put into every operation for success or for failure. It's not a pill, it's not an injection, a new dose, a different tablet, an altered regimen. It's a transference directly of a palpable, manual, dexterous self, which within a few hours determines the future for each and every patient. What a privilege to have and to be able to use this training and skill And the results, the outcomes for good or ill are immediate. There is no waiting around. The effect is almost instant. But the failures too often are felt to be personal and cast you deep into the realms of self-doubt and even professional despair. This dark place haunts all surgeons, and the fear of failure drives us on towards the excellence we strive for. Yet perfection is not possible. We are all complex human systems which can fail. As a senior registrar in vascular surgery, I learned more than any other time how to confront fear, to make rapid decisions on the balance of probabilities and weigh up risks, develop strategies and fall back on first principles. As a surgeon, being frightened is not a positive emotion. Dealing with complexities, knowing that catastrophe is just lurking nearby, takes discipline and focused reasoned strategy, steely determination, and a total avoidance of panic. As a child, I grew up in a home where one parent was a church minister and the other was a qualified teacher. Although my mum, who was the teacher, didn't teach for long because they moved to Scotland where she couldn't use her qualification at the time, which was English. But my brother and I knew exactly what we were expected to do when we grew up. Being a minister, of course, was up there, and being a teacher was absolutely up there and was just fine. But I knew from an early age that neither of these really was to be my future. From the age of somewhere, I don't know, maybe around 8, almost the only thing I wanted to do was to become a doctor. And that was a problem. I was coasting along in the middle of a class of about 48 other children, and I did not seem particularly promising. But I was so impressionable, and I loved the Jungle Doctor book series. And I could imagine in the future being in some foreign land, delivering babies by the light of kerosene lamps, snatching people from the jaws of illness, and living the part and writing my own Jungle Doctor books. Well, I've written my own book about being a surgeon, and I hope it's going to be published probably sometime next year or the year after. That was half a chapter from it. But it took a change of school subsequent to a move for our parents to another part of the country for an irascible and impatient schoolmaster to call my parents one day and ask them to come in and tell them face to face that if he was allowed to make me work properly, he might be able to find some promise. And so it was that I started onward up the stepladder of schooling, university education and training, with multiple exams that straddled over 2 decades, and all deeply punctuated with doubts, fears of failure, periods of elation tinged with skepticism that I would actually make it. I viewed every step as a challenge and tackled it head on with essential determination and hard work. Medicine was never just to me a job. It was unquestionably a calling, a vocation. And having attained the initial medical degree and qualification, it seemed only right to carry on climbing as far as I could, and for as long as I could, up the steep pyramid that was deemed surgical training. The first 2 decades meant 80, 90, sometimes 100 hours a week in hospital, dealing with everything that humanity threw in the direction of whichever department I was working in. And I was so privileged to have Eileen, my life partner, who fully supported those exhausting but unmatchable years with encouragement at every stage, even while she too was following the same trajectory in pediatrics. There's so many stories that we both could tell, working hospital Christmases with our own little 2 children on our laps, or them being looked after by a nurse at the end of the ward while we got on with the work in theatre or intensive care. Maybe that's a talk for another time. But we both fully expected at any moment the call would come from the church institution to go overseas and work as medics in an underprivileged country. Eileen had grown up in East Africa with expat missionary parents, and was so acclimatized to that life. And we had both experienced short periods working as medics in Hong Kong, Tanzania, East Africa, as well as Pakistan. But that call never came. In fact, that's not strictly true. We did have one call once after I'd become a fully qualified surgeon, and Eileen was a fully qualified pediatrician. We did get a call from the division to go to West Africa, but the job was for me to go as a physician's assistant and for Eileen to go as a nurse. So that didn't quite work with the fact that we were already fully qualified postgraduate trained specialists. So that brings me on to this talk today, because in fact, this is the first time that I have ever in my career been asked to give a presentation to a church audience at this level and on this scale, which, if you think about that objectively, is quite astonishing. It seems there's sometimes a definite but uneasy alliance between church and medicine. And the higher profile you achieve in medicine or surgery, seemingly the greater the unease. How can it be like this? Especially as the longer that Eileen and I work in medicine, the more obvious the intersections between medicine and ecclesiastical life become apparent. What's so amazing about the experience as a medic is the extraordinary pageantry of humanity that we see and treat and interact with. Everybody is a child of God. We are so all the same. I have spent a lot of time in India. I've visited India well over 20 times, lecturing, teaching, training, operating. I did get registered with the Indian Medical Association once so I could operate. And I've been teaching all the techniques of breast cancer surgery and breast reconstruction, and that has been an extraordinary experience. And to think in that teeming country where the streets are filled with millions of souls, every single one is the same. And each of us have the same needs, the fears, the desires, the basic wants, the health issues. We need food, we need security, we need clean water, we need protection for our loved ones, we want a secure future, we want comfort, we want peace. No matter what we hide behind, no matter what toys we have that we can play with, no matter what positions we have in politics or business or don't have, we have the same bodies. And I cannot imagine a more whole human experience than we find as being in a vocation of medicine. It's overwhelmingly a calling. It's overwhelmingly a privilege. So how did I get into doing breast cancer surgery? Well, as you heard from that segment I read to you, my initial trajectory was as a vascular surgeon doing arterial surgery, exciting, fast, moving, and yet in many ways quite limited. And in some ways, we've seen over the last 10 to 15 years, a lot of vascular surgery has now become not quite extinct, but it's become subsumed by endoscopic radiology, for example. But anyway, it also impacts quite a narrow dynamic of humanity. How did I get into breast cancer surgery? Well, when I was a registrar, the only way that you would even get shortlisted for a senior registrar post, which was the next in the scale before consultant, was by having 2 years of research and having a higher doctorate by thesis and publishing. And I tried at the time to get one in vascular surgery, but there were just none going in the whole country. There was one going in Harvard, And one of my colleagues took that, and my mentor said, I'm not sending you because there isn't a post there for Eileen, and actually it'd be quite nice to keep you both together. He was very fond of Eileen. And then a professor of breast surgery called me, and he said, I've got a research fellowship, would you like to do it? And I said, no. And then a week later he called and he said, I've got money from Cancer Research UK, do you want to do it? And I said, no. And that conversation went on for 3 weeks. And then he called me and he said, listen, he said, you don't turn these things down. He said, go and do it, get your degree, get your research, and then come back into vascular surgery. And that's what I did. And I spent 2 years, partly at the Courtauld Institute of Biochemistry in London at the Middlesex, and partly at the Patterson Cancer Research Institute at the Christie. And I commuted between the two, a week on and a week off. And I hated it. Breast cancer surgery had not changed for 40 years. It was crude, it was brutal, it was often done by the most junior members of the surgical team. And the results were shocking. The mortality rate was 80% from breast cancer. And this is only in the mid-1990s. After 9 or 10 months doing this research, I started to get some really interesting results. We were looking at trying to find genes for response to different treatments, medical treatments in breast cancer. And 2 years later, I emerged with a doctoral thesis. I had 27 published peer-reviewed papers, and I had learned to think. And I went back into my surgical registrar training. I got appointed. I did almost 2 years in vascular surgery as an SR. But everything then was still very much general surgery with a specialist interest. And when I went back to work on the breast surgery unit for a year, I just said, how can this be? At the same time, there were people developing techniques of reconstructive surgery, both in Britain and in the US, but they were reconstructive surgeons with no interest or knowledge very much of the cancer and the oncology. And the cancer surgical oncologists had very little interest in the reconstructive side or even the psychological side, to be honest. And so I did some quite extraordinary things. I went everywhere I could go to learn reconstructive surgery with the blessing of my mentors. I did several years of plastic and reconstructive surgery training. I went to New York, I went to Atlanta, I went to Dusseldorf, and everywhere in Britain where I could go. And when I was appointed a consultant, which is just over 25 years ago, within a very short period of time, I developed what has become known as oncoplastic breast surgery with some like-minded people. And the rest, I think you've seen the way that breast cancer care has transformed over the last 20 years, and it's been a huge privilege to be part of that. And now we have the reverse. We have over 80% of people who have this surgery and this diagnosis surviving without recurrence, and functionally and aesthetically surviving well, and as far as I can do anything for it, as looking and living as normally as possible. And it's quite interesting at this point in my career to be told sometimes I'm not wanted to give talks because I'm a male. Occasionally, I see patients who don't want to see me because I'm male. They'd rather see the female second-year medical student in clinic. And that's hard. And it raises the question as to what prejudices do we have? And I have so seldom been asked to give talks in church circumstances. And I even recently had a message saying they'd like your talk, but they'd like a lady to give it. How can this be? And we've realized, Eileen and I, over the last few years, that our calling has been here. It hasn't been overseas in a third world country, although it's been wonderful to have influence in some of those places and to be able to teach. But our world has been here. And through the work and through the world that I work in, it's been an enormous privilege to look after some of the highest profile women in this country. And Eileen said, no, she said, it's not in this country, it's in the world. Well, I wouldn't say that, but it's been a real privilege to do that. And what a leading that has been. And many of them are personal friends. But to be able to live and to show the love as a Christian that every individual has got this input, that every person matters, every person is the same, and every person has all these needs. And to sit with people with success and also to sit with people with grief. I realized a long time ago that actually I make a lot of my patients cry. I make them cry if I give them bad news, and that's totally understandable. I make them cry if I give them good news, which is a bit less understandable. I treated a patient from Russia. I've actually treated a lot of patients from Russia. But this patient came in and spoke no English and always came with an interpreter who was an older man. And every time I saw her, she had a completely implacable face, no expression. She was from Moscow. And every time I said something to her, he would interpret it, and her reaction would be featureless. I took her through surgery, reconstructive surgery, adjuvant treatment. By the way, there's about 27 different types of breast cancer, and they all need slightly different treatment and different adjuvant treatment. So it isn't one size fits all. Some of it is highly aggressive, other is much less so, and it behaves in a completely different way. There is not one breast cancer. And that's another thing that's come out in the last 15 years. And that's kind of come from partly from the research we were doing back in the early 90s. Anyway, at the end, when everything had been finished, I just, she was on straight and level and was now just going to be followed up once a year. And I said, is there anything else that she wants to ask me? And the interpreter said to her in Russian, he says, is there anything else you want to ask her? Yes, she says. She says, can she give you a Russian hug? And so this woman stood up and gave me this enormous hug. And for the first time in months, her eyes smiled and she laughed. It just shows how our cultures and how our sensitivities are so impacted by the society in which we live. But that was a very, very precious moment. A lot has been said recently in the media about doctors, about GPs, about coronavirus. There's been a lot of awful stuff said and written, as well as good stuff. It's been one of the hardest 18 months that I think any of us has faced, and we are still facing. I had a couple of months last year when I didn't see patients face to face, but by the end of May, I was back operating on patients with cancer, wearing full PPE, polycarbonate mask, respirator, the lot, operating for people whose cancers had to be treated, and never knowing whether that person in front of us in theatre was going to be the one who infected us, knowing that we were the demographic that actually could be really ill. And of course, 8 months went by before we got tests, before we got vaccination. And I remember getting the invitation for the vaccination, and boy, we were there early waiting. I had my booster last Friday. We were there early, I tell you. We were there early to get the booster, because that has been the single most thing that has protected us. Well over 1,000 doctors have died in the last 18 months in this country from catching coronavirus from their patients. And we know some of them. We went down to the Thames a few months ago, Eileen and I, and we wrote the name of a colleague on the wall who died a few months ago, age 61, no previous illness, a chest physician, a consultant. And to hear people deny this and say it's a con, it's a fraud, words fail me. Words absolutely fail me. And it's still going on. And to be a doctor in the middle of all of this is not easy. Okay, many without doubt just see it as a job, as a way of, paying the bills. But medicine has always been supposed to be a vocation. And if you look at the name vocation, it comes back. The old French vocation means a personal calling to an occupation or a profession that a person was particularly pulled to. And its origins were, of course, in religious orders. And it was only in the early 20th century it started being applied to other skills. It always was the church. It still is the church. And the need of ministers to understand that the calling is still there to hold people in their arms psychologically and spiritually at every stage in life is so important. And if someone experiences a bereavement, not just to direct them to a website of grief counseling, but to be there in person, spiritually holding them with the representative arms of God. And I say that having spent the last 4 decades in medicine. The crossover is so there. It so is. And also being in the specialism now that I am in, I feel so strongly that the way we look at women has to change. So many of my patients are some of the highest politicians, the highest business people, the highest academics, with skills that make their male colleagues look weak by comparison. Just think about what we do inside our church, institutionally. It cannot be right. And I think that at the moment, it's important for all of us as individuals just to keep that in our minds. Finally, there was a big industrial company a few years ago that saw their share of business falling. It's a multi-billion pound company. And they made drill bits and machinery, industrial kit. And in order to try and get back their status, they started to have groups of think tanks together, what they could do. And what do we do? What do we do? Well, at the basic level, what do we do is we drill holes. It took some months for them to come up with the company that makes the equipment, that makes the drill bits, that drills holes. This is the company that builds bridges, hospitals, schools, homes. And they put that out as their new business mantra. And immediately their whole standing started to go up. and their bottom line went up and they became financially extremely strong again. A psychologist called Angela Duckworth did some work on 16,000 adults about their work and their vocation. And she found, perhaps surprisingly, having a calling, feeling a vocation, has very little to do with actually what you do. She found rubbish collectors, secretaries, wine critics, chefs, teachers, all equally likely to say that they found their job is a calling. It's not that some jobs, occupations are just jobs and others are calling. She says rather it's how you see your work that is more important than your job title. We can all make our jobs into callings, sometimes without even changing what we do. Jobs become callings when they transcend me. People who view their jobs as callings, they work for the sake of it, not for external gains or position or social status. And in turn, intrinsic motivation, which is what a calling is, improves achievement, determination, motivation, and psychological health. That's what Duckworth has written in one of her papers. A calling is a feeling that the work just has to be done. And as a child, I just felt I had to be a doctor. And unfortunately, others around me saw that and helped me focus to do it. A calling connects us to something greater than ourselves. Duckworth says, the long days and evening of toil, the sacrifices, all this is worth it because our efforts pay dividends to other people. We make a difference. We continually ask how and what we can do that connects to other people in the bigger picture. And how can that be an expression of our deepest values? A bricklayer who one day says, I am laying bricks, may well at some point become the bricklayer who says, I am building the house of God. Thank you for listening.